Asian Pacific Society of Cardiology, supported by the Singapore Cardiac Society, EBAC accredited for CME points in collaboration with AstraZeneca. My name is Jack from Singapore. I'm chairing this session together with my good colleague, Dr. Julian Low. He's the director of the Coronary Care Unit, as well as a heart failure specialist. We have two esteemed speakers, respectively from Singapore. We have Professor David Sim, the director of the Heart Failure Service, as well as Deputy Head Senior Consultant at National Heart Centre, Singapore. He's going to speak to HFpEF management in 2022 and an update on the definition and the diagnosis. Professor Chern-En is our usual panelist and speaker. We're very privileged to have him from Taiwan. He's a professor of medicine at the National Yang-Ming University. He's then going to speak to Deliver and Emperor Preserve. How consistent are the results for HFpEF management? We have then will be followed by two case presentation and discussion presented by Dr. Hawani from Indonesia, and our co-chair, Julian, is then going to do a second case narration. Our panelist for today is Dr. Alan Fong from Sarawak General Hospital, the current president of the National Heart Association of Malaysia. Some disclaimers. This content is copyrighted by the APSC. The views expressed here belong solely to the faculty members and do not necessarily represent those of the APSC. This webinar is currently now made live stream via Wonder, APSC Facebook and YouTube pages. CME points will be accredited to those who are connected throughout the full duration of this Zoom webinar. You will then receive your certificate of attendance upon completing a survey sent by email. Please do click onto the Q&A box below and we'll try to answer all questions surfaced. So let's get started, and I'd like to welcome my good colleague, Professor Sim, to talk about what's the new definition for HFpEF management in 2022. David, please.
Yep, thank you, Jack, for the very kind introduction. Let me share my screen. Okay, thank you very much. So I've given this topic of to talk about HFpEF, about the diagnosis and all that in year 2022. These are my declaration of interest. So let's first define what is HFpEF. I think when we were in medical school, we were taught the HFpEF. We were actually we don't use the word HFpEF in the past. We use it as diastolic heart failure, and then corresponding will be systolic heart failure. But nowadays, we know the nomenclature, we're now changing it to HFrEF, that is ejection fraction less than or equal to 40%, and HFpEF is designed as more than or equal to 50%. And right in the center, sandwich between the two, is that of mildly reduced ejection fraction, 41 to 49%. And of course, we have another group, what we call heart failure with improved ejection fraction. These are patients previously with less than 40%, but after treatment, they have improved to more than 40%. So essentially, 4 different categories of heart failure according to the ejection fraction. And we do know that heart failure with HFpEF, what we're interested in today, this group of patients are no different from those patients with HFrEF. They have a high, incidence of, hospitalization. In fact, heart failure hospitalization is the #1 cause for patients above 65 years old. And before the SGLT2 inhibitor as a class of drug, which the second speaker will elaborate a bit more, there were actually no clinically proven therapy for this group of patients to reduce their mortality and morbidity. And we do know that heart failure hospitalization has the greatest impact on patients with heart failure. This is a registry taken from Italy. So when they do survey the patient, you can see that those patients who are being surveyed, they will say that being hospitalized, that causes the worst quality of life compared with other symptoms such as shortness of breath, feeling fatigue, unable to walk far. So actually being confined in hospital to the patient is the worst outcome in terms of QOL. And not only that, we do know that heart failure hospitalization, they do account for a big chunk. In fact, 80% of the total cost of the treatment of heart failure with preserved ejection fraction. So you can see the outpatient cost, all that actually account for a small percentage only. the majority of the burden, socio-economic burden actually lies in the recurrent admission for this group of patients. So back to the definition of heart failure. In the year 2021, we have from APSC, from the latest guideline, the ejection fraction is again defining into HFrEF, mildly reduced, and preserved ejection fraction. But do take note, for HFpEF, we not only base it on ejection fraction and just signs and symptom, we need other criteria as well. So we can't just label somebody with shortness of breath, with ejection fraction more than 50% as HFpEF. We need cardiac structural or functional abnormalities, in order to diagnose this patient having HFpEF. So in the next few slides, I'll elaborate a bit more what I mean. So you can see that majority of the evidence for cardiac structural or functional kind of derangement is in the echo finding, looking at the LA volume, the E/E prime, which is a good surrogate marker of the LV filling pressure, and the LV mass index. At the same time, the biomarker is also very important in the diagnosis of patient with HFpEF. So we need a combination of imaging abnormalities and biomarker elevation in order to diagnose somebody to have HFpEF. So this is from a European side, the ESC, the diagnostic algorithm for heart failure. After a careful history and physical examination and ECG, we then go on to do what we call a NT-proBNP or BNP. And if it is negative, do consider other diagnoses. Heart failure become very unlikely. But it is positive, we proceed on to do an echocardiogram. And based on the echo finding, together NT-proBNP or BNP, we then determine which category of heart failure the patient belongs to. And the European side actually come up with this they come up with a HFpEF score. So this is what they, again, depending on the scoring system, they will divide the patient into low risk, intermediate risk, or high risk of having HFpEF. For those having intermediate risk, they will then, suggest to either go for invasive diastolic stress test or non-invasive diastolic stress test to confirm the diagnosis of HFpEF. So what exactly is this score? You can see here, the scoring is actually based very much, again, on echo finding and on the biomarker finding as well. And do take note, the point system for sinus rhythm and for atrial fibrillation is different. For patients with atrial fibrillation, we do expect a higher NT-proBNP compared to those patients with sinus rhythm, and the functional finding and the morphological finding on the echo as well. So based on all these findings, they are given a point system. Anything more than or equal to 5 points likely to have HFpEF. Anything between 2 to 4 is intermediate, so that we will suggest to go on to do what we call a diastolic stress test or some form of invasive hemodynamic measurement, a right heart study. So in cases when the score is intermediate, this is what we can do. We can either subject the patient to stress echo and look at the E/E prime. If the E/E prime become elevated, then we can diagnose this patient having a HFpEF. At the same time, another method of doing it is to perform a right heart study, looking at rest. If the LV filling pressure or the wedge is high, then we can diagnose HFpEF as well. If not, we can perform some form of exercise, for example, bicycle during the right heart study and look for a elevation in the wedge pressure itself. So that itself is also a sign of HFpEF. And if it's already not confusing enough from the European side, we have also from the other side of the Atlantic, from the US, they came with this H2FpEF score. As you can see here, H2FpEF score is also another scoring system looking at how likely the patient is going to have HFpEF. As you can see here, the biomarker is actually not included here. There are things like the weight of the patient, whether the patient hypertension, atrial fibrillation, presence of pulmonary hypertension, the age, and lastly, the filling pressure. So based on this scoring system, again, the higher the score, the higher the probability of the patient having HFpEF. But the side different from the European side is you don't really need to have elevated biomarker in this scoring system. So that make the diagnosis of HFpEF sometimes not so straightforward. And depending on which scoring system we use, the probability may also be different depending on the different scoring system I personally don't use a lot of this H2F PEF score because of the lack of biomarker included here. So let us first look at some of the previous trial, that were conducted in our patient with HFpEF. The first trial that I want to touch on is that of sacubitril valsartan. We know that sacubitril valsartan, or as a class of drug, what we call ARNI, has now been established as a standard of care in patients with heart failure with reduced ejection fraction. This drug has been shown to restore the neurohormonal imbalance. And in the phase 2 trial previously, the Paramount trial, the use of sacubitril valsartan when compared with valsartan did show an improvement in NT-proBNP, improvement in LA size, and lastly, an improvement in the NYHA class status as well. So because of this encouraging result from a phase 2 trial, we proceed on to a phase 3 trial, the Paragon HF trial, which was released the result a few years ago. And this trial, in the comparison of sacubitril valsartan versus valsartan, in the setting of patient ejection fraction 45% and above, the primary outcome was that of cardiovascular death and heart failure hospitalization. Unfortunately, in that trial, despite there was a positive trend towards less event in the sacubitril valsartan arm, the p-value just narrowly missed the significant, p equal to 0.059. And also interestingly, from the Paragon HF trial, when we look at subgroup analysis, there was a gender difference. Female patient seems to respond to a drug, while male patient, the effect was neutral. At the same time, we also look at the treatment effect by ejection fraction, and there was a suggestion that in those patients with mildly reduced and EF about around in the 50s, that's less than 57%, the drug seems to work. But as the EF become more than 57%, especially more than 60%, the effect of the drug is attenuated. And this attenuation of the effect of the drug is not just confined to ARNI. Previous study of the TOPCAT, if you remember, TOPCAT was the use of spironolactone in our HFpEF patient, also show the same effect. As the ejection fraction approaches 60% and above, the effect of MRA or spironolactone in HFpEF patient is lost. And again, you can see this is mildly reduced ejection fraction, looking at it, and also HFpEF patient. As the ejection fraction increases, the effect of the drug wear off. Same thing for ARB. We do have the canisartan being used in the Chiang study, the Chiang preserve, and in the HFrEF arm and the mildly reduced arm, the drug seems to work with a significant p-value, but once the ejection fraction crosses 50%, canisartan seems not to work with a p-value of 0.57. So it seems that from ARNI to MRA to ARB, we do see this trend of in the higher ejection fraction, the effect of the drug wear off. So we move to our new highlight for today. That is the story of SGLT2 inhibition in heart failure. What started off as a diabetes drug, we know that now has been tested not just in HFrEF patient, but also in two big trials, the Emperor Preserve and the Deliver trial, which the next speaker will elaborate a bit more. So I just go through very briefly on SGLT2 inhibitor. The first trial we had is Emperor Preserve trial that was released last year, looking at patients more than 40%. So technically, it's not just a preserve trial. It's a combination of mildly reduced and preserved patient looking at empagliflozin versus placebo. And for the first time, we do have a statistically significant positive trial for HFpEF patient with a 21% relative risk reduction. The primary endpoint was that of cardiovascular death or heart failure hospitalization, but mainly driven by a reduction in heart failure hospitalization. And do take note, the drug became effective as early as day 18. You see a splitting of the primary outcome. Subgroup analysis, fortunately, did not show what the ARNI, show. Both group of patients, male and female patient, responded equally well to the drug. And again, different ejection fraction, whether it's less than 50% to more than 60%, all different subgroup of patients responded equally well as well. Quick one on Deliver, which I think the next speaker will elaborate a bit more. Same concept, we are now using a different SGLT2 inhibitor, dapagliflozin, in this setting. Again, ejection fraction 40 and above, What is different, which I'll point out, is this group, we also included heart failure improved ejection fraction. That is previously with ejection fraction less than 40%, but now improved, they are also allowed to take part. And of course, 16% of them actually had a recent readmission, recent hospitalization for heart failure. So there's a mixture, a little bit of acute heart failure in this trial as well. And of course, we know that the result was positive. So quick summary here, relative risk reduction 18%. Do take note, primary endpoint was slightly different from EMPEROR Preserve. We do include patients who will go to the ED or to the clinic as well. So I just skip through this slide because the next speaker, I'm quite sure, will elaborate a bit more with you guys. But just what I want to point out is both DAPA and EMPA, across the whole continuum of ejection fraction, you can see that hazard ratio remains below 1. But we can't say the same for all other agents. You can see here very clearly the ARNI, MRA, and the digoxin. Once the ejection fraction crosses 50 to 60%, that's where you see attenuation of the effect of the drug. So in the year 2022, now we have the 4 corticosteroid therapy for patients with HFrEF. That is ARNI, or if they can't afford it, ACE inhibitor, ARB, MRA, beta blocker, and lastly, a SGLT2 with or without diabetes in the setting of ejection fraction of 40% or below. And now we do have from a guideline, the ACC/AHA guideline that has, based on the EMPEROR Preserve result, has updated the guideline early this year to include for mildly reduced ejection fraction and preserved ejection fraction, the SGLT2 inhibitor as a class 2A indication. All other medication are given a 2B indication because of the neutrality of the trial. I'm quite sure with the DELIVER study now, this 2A indication will most likely in the future be upgraded to a class 1 indication. Thank you for your attention.
Thank you very much, Professor Sim. That was a very enlightening talk, especially with regards to the history of our clinical trials in HFpEF and why it has been so challenging to find an appropriate therapy for this. If there are any questions, please do feel free to put it up in the Q&A box. But perhaps I might start off the discussion by asking you about Prof. Sim about the difficulty in diagnosing the HFpEF. And you talked a bit about the scores, and you said personally we don't use the scores that often locally in our center. So what do you use when you want to try to diagnose this difficult entity of HFpEF?
Yes, so the reason why I don't use the American score, the H2F PEF score, is because based on the score, it's very easy to diagnose the HFpEF. All you need is hypertension, old age, a bit on the obese side, you will be labeled as having a HFpEF already, which I think will overdiagnose the patient. So I personally, I still use what the European are doing. And it's the European, I think, definition is also good to use because in both the EMPEROR Preserve and the DELIVER trial, the inclusion criteria will include patients who need to elevated biomarker, that is a BNP or NT-proBNP, and they need to have some structural changes on the echo. There's either a enlarged LA size or some form of LVH. And based on this, the patient will enroll in the trial. So I usually would make sure that, I do echo, look for all these changes, and I do an NT-proBNP to make sure elevated. Because this is a group of patients or a subgroup of HFpEF patient that we know in the trial will respond to the SGLT2 inhibitor, whether it's dapagliflozin or empagliflozin. Of course, there's the other group of patients that they have no symptom at rest, or at rest their feeling pressure is normal. Only during a stress echo or during a right heart study that you diagnose them. That group of patient, unfortunately, was not represented in the 2 trials. So will this drug work in this group of patient? I think it will work, but unless we do a formal study in this group of patient, it's probably still an evidence-free zone.
Thank you. Sorry, I see some raised hands. Did anybody want to?
Alan can go first. Yeah, you have a question, comment?
Yeah, I think thank you very much for a fascinating lecture. And I just wonder, in the context of many of our delegates across the APSC, maybe you could help us understand why the pathophysiology of HFpEF in your opinion? Because as we, one of the patients recently asked me that is everybody going to get it? Because as we get older, so it's difficult to answer that. So may I ask your opinion on this?
Very difficult question. Itself warrant a lecture, but I try my best. So first, I don't think everybody will get HFpEF. There are a lot of studies that's done that show that if you go out in the community, you put an echo probe on elderly patient, it's very easy to get diastolic dysfunction. So a lot of patients out there will have, elderly patient with diastolic dysfunction, whether it's grade 1, grade 2, or grade 3 or grade 4. But not all of them were symptom. Not all diastolic dysfunction will end up having HFpEF. That's why we avoid using diastolic dysfunction on echo as a diagnosis. So we are not sure why some of these patients with diastolic dysfunction echo, they do not go on to develop full-blown HFpEF. So as for the pathophysiologies, I think it is got to do with, probably we do know that in this group of patients, there's a lot of fibrosis, in this group of patients. There's also some implication of, inflammatory changes, microvascular changes as well. So the exact mechanism, I don't think anyone can pinpoint. I think it's probably a combination of everything. That is probably the reason why I think SGLT2 inhibitor as a class of drug have worked in HFpEF, whereas the other drug that mainly target the neurohormonal so-called imbalance, such as ACE inhibitor, ARB, MRA, beta blocker, or even ARNI, have failed to show benefit in the HFpEF trial. Whereas SGLT2 inhibitor, we know they work by different mechanisms. Some of the postulated mechanism is they causes less fibrosis, they causes less inflammation, and also the use of SGLT2 also has been shown to reduce cell death. In our heart, actually, there's a lot of ongoing program cell death. The use of SGLT2 has been shown to, slow down the cell death. So these are many of the mechanisms that have been proposed. And of course, we do know that SGLT2 also has a mild diuretic effect and is different from the usual diuretics because what it targets is your interstitial fluid rather than intravascular fluid. So these are some of the postulation, that we think make this drug works in this group of patients who are very different from a usual poor EF patient in terms of the underlying pathophysiology.
Thank you very much, because this leads up to the next issue, because the current algorithm recommends the use of biomarkers early so that you can screen the patient early and then perhaps confirm the diagnosis by echocardiography. Now that we have treatments that can effectively improve the outcomes of these patients, by adopting more of this strategy of doing a biomarker screening in a higher risk population, do you think that we will end up picking up a whole lot more of this condition to treat? And are we going to be over-treating the patient?
Yes, I think if you were to deploy the use of biomarker, in the primary care setting in elderly patient who present with very non-specific breathlessness, you're going to probably pick up a lot more cases. But I think after picking up, the patient with the raised biomarker, I will not say immediately label them a HFpEF. You still need to refer them to get a formal imaging done, and at the same time, I think you need to prove that. Just having a high biomarker doesn't mean the patient has HFpEF, because there are other causes of the raised biomarker. For example, sepsis, renal impairment, all this can cause a raised biomarker as well. But I think I will personally think that in Asia Pacific region, where echo is not so highly available to most center and to most patients, it's probably more cost effective to, if the blood test can get subsidized, to get it done. It's much easier to perform a blood test rather than sending a patient for echo. That's what I think. And if the biomarker, like I say, is normal, it's very, very unlikely, this patient is going to have heart failure. I will then stop there and will not pursue a cardiac cause for it and look for other causes for the shortness of breath.
Thank you very much, because it's just coming off the COVID-19 pandemic. So perhaps a biomarker is like a rapid test, and the echo becomes more like a PCR.
Yes,
okay.
And we do have now the biomarker, the NT-proBNP and the BNP. They have point of care assay nowadays. That means you literally can do it in front of you in your clinic. Yeah.
Okay, thank you very much. Professor Jack Tan, did you have a question?
Yeah, I had, but I thought I'll maybe reserve it after the next lecture because this I don't want to delay the session. So maybe after Prof. Chiang's session. The question to Prime Prof. Chiang is, I felt the definition for simple cardiologists like me, should they just take out the mildly reduced EF segment and just say 50 below and above, because the treatment seems to segregate at the 50 mark in the future. I don't know whether there's a question to be addressed later. But I think I'll be very good to hear Prof. Chiang's lecture first before we go into that. Thank you, Prof.
So should I be started?
Yeah, please. Thanks, Prof. Chiang.
Okay, thank you very much, Dr. Clin, for your kind invitation. So my topic is how consistent are the results for the HFpEF management. So this is my disclosure. And interestingly, when you look at the two important drugs and the four important trials, you can see very beautifully they actually separate for exactly 1 year, 2019, 2020, 2021, and 2022. So exactly 1 year difference. So we now have the ample evidence to suggest the role of the HG2 in HFrEF and HFpEF. So Emperor Preserve was the first one. I quite agree with David said this is the first landmark trial to confirm the role of HG2 in patients with HFpEF and mild reduced ejection fraction. 21% reduction primary endpoint, and then T was at 31. It's interesting. And the result was mainly driven by the reduction of hospitalization for heart failure. There is quite a small change of the CV test, and the all-cause test was actually not, there's no effect at all. I have to remind you to see a reduction in total mortality in patients with HFpEF is difficult. This slide show the HFrEF study. You can see the CV deaths actually account for about even to 90% of total deaths. So if the drug can decrease CV deaths, would certainly have a high chance to decrease the total deaths. But when you see the HFpEF trial, actually it's about 50 to at most 60% of the total deaths was accounted for by the CV deaths. So unless your CV deaths was reduced quite a lot, otherwise you will not see a reduction in total deaths. And one of the drawbacks of the Emperor Preserve that you can see the efficacy of empagliflozin was actually attenuated in a patient with a high ejection fraction, especially greater than 60. And they actually do the so-called pool analysis of the empagliflozin combined with Emperor Preserve and Emperor Reduce. So the conclusion was there was attenuation in patients with ejection fraction greater than 65. So the weakness of Emperor Preserve is that we just saw there is attenuation in the highest part of ejection fraction range. The other part is that the Emperor Preserve didn't include the patient who was in hospital in the acute phase. And mentioned by David previously that actually Emperor Preserve trial excluded patient with so-called improved ejection fraction. That is the patient with the previous ejection less than 40, now greater than 40 or 50. So the liver trial is interesting, just announced about 1 month ago. And the two important chairmen shown here, and it's very, very good to Asian doctor. You can see we have a group discussion with John Murray. And the rationale for this trial is that we know that Emperor Preserve was successful, but they have 3 drawbacks I just mentioned: attenuation in the patient with higher ejection fraction. There's no improvement of the patient in hospital, and we have no data of the patient with improved ejection fraction. So study was actually include more than 6,000 patients. It's the largest HFpEF trial. In fact, the patient including patient with HFpEF, mild reduced, and also patient with a normal ejection fraction. Greater than 40 years old, function 2 to 4, LVEF greater than 40, and they have to have some structural changes, as mentioned by David, and elevate biomarker. And also this study included in-hospital patient. It's very easy to use, no titration was needed, single dose from the beginning to the end. double-blind study, and you can see there are two. There's combined primary endpoint is CV days plus worsening heart failure, including the urgent heart failure visit. There are 4 different secondary endpoint: total hospital heart failure event, KCC group changes, CV days, and all-cause days. And because there is no attenuation of the effect in the patient with higher ejection fraction, so actually the protocol was amended to include the 2 dual primary analysis. The right-hand side is the original analysis, and then they add another arm to see if the patient with the ejection fraction less than 60. So this is a flow chart of the study. 6,263 patients evenly distributed in the dapagliflozin and the placebo group. 2 points which was need to be mentioned. The discontinuation due to drug was 14.2%, almost the same in the treatment arm and the placebo arm. And what's more interesting was the loss of follow-up was only 0.06%. If you compare our loss of follow-up in the Emperor Preserve and Deliver, you can see SIM Deliver was the winner. If you look back to the HFpEF trial, you can see also, again, the loss of follow-up in the DAPA-HF was much less than that in the Emperor Reduce. For the discontinuation in the Emperor Preserve, I just mentioned, Deliver was 42%, but when you look back on the Emperor Preserve, it's 23.2%. If you combine all major trials for the HFpEF, it's interestingly because DAPA-HF, Soloist, even Victoria, has about 10% of discontinuation. However, in Emperor Reduce, it's more than 20%. So the study includes 20 countries. Taiwan enrolled more than 318 is at number 9 in that. We know Taiwan is a small country, but we are very, very doing a good job in this trial. And the age was 72 years old, female 44%, baseline ejection fraction of 54%, quite similar to the Emperor Preserve. And the Asian people about 20%. And the patient mostly are the so-called not very symptomatic functional class 2 trial, functional class 2, the New Heart Association. And NT-proBNP was 700 in patient with AF, so it's about 14, about twofold of the patient with sinus rhythm. And interestingly, more than 40% of patients have the atrial fibrillation and concomitant diabetes. And the medication shown here, although we know that there was no effective drug at all at the previous, about 2 to 3 years ago, but still the patient, the physician prescribed MRA probably due to some meta-analysis result. And when we compare the Deliver and the Emperor Preserve, you can see the Deliver include in-hospital patient, and the inclusion for LVEF, EGFR was 25, 20 was in the Emperor part, and the blood pressure is slight difference, and also the endpoint of the Deliver include the patient with urgent visit, and the endpoint of the different heart failure was different. But you see the DAPA study, in the dapagliflozin study, they always include the patient with urgent heart failure, put together with heart failure hospitalization called worsening heart failure. Is different from other trials. And the functional class, you can see, it seems that in Deliver trial, patient has more symptomatic with higher NT-proBNP and the higher percentage of the heart failure history, admission history. So you can imagine the baseline risk for the Deliver is slightly higher than the Emperor Preserve. When you see the placebo group, you can also see the phenomenon. Primary endpoint, although there's different definition, but Deliver was higher than. CV days was the same, but total days was actually higher in Deliver trial. So this is the Kaplan-Meier curve of primary endpoint, 18%. Because the definition was different, when you use the same definition as Emperor Preserve is 20%. It's almost the same. And the so-called NNT was also equal, 32 versus 31 in the Emperor Preserve. Again, the effect was mainly driven by the reduction of the worsening heart failure, 21%. There was a gradual separation of the CV days, about 12%. I have to remind you that the study was not powered enough to see a difference in CV days. If you want to see a difference in CV days, the sample size should be increased. The first interesting finding is that there is no attenuation of the effect of dapagliflozin in the Deliver trial shown in the upper panel. And an in-hospital patient we can also see there is efficacy the same. P4 injection was actually greater than 0.05. The data has been accepted online in the check. You can see the worsening heart failure in the upper two line was higher, but the efficacy, the reduction of the relative risk reduction was the same. And finally, this is the first study confirmed that HTT2 might be effective in patients with so-called improved ejection fraction. And the second endpoint, first one is the total heart failure event. You can see there is a reduction of the dapagliflozin on the right-hand side, 23% of the second endpoint. The second endpoint was improvement of KCCQ. Total symptom score, you can see 2.4 point difference between the dapagliflozin and the placebo. If you want to see the clinical relevant, that means that the change of the KCCQ greater than 5 points, 10 points, 15 points, you can see that dapagliflozin was actually better than in the placebo group. Actually, the mean change in KCCQ in the emperor preserve was not significant, shown here. And the adverse event shown here, any AE leading to treatment discontinuation was exactly the same in the dapagliflozin versus placebo. We see the whole full spectrum of that adverse event is quite similar. You can call it placebo-like adverse event. So the conclusion of this trial was the trial is the largest, the most inclusive trial on patients with the mild reduced or preserved ejection fraction. And the study confirmed the primary composite endpoint was successful. And the total heart failure event and the symptom improvement was successful. And across of the pre-specified subgroup, including there is no attenuation in the highest LVEF group. And the study was confirmed the HTT2 was effective in patients with improved ejection fraction. And the AE and the drug discontinuation due to the AE was the same. So the conclusion, if we make a sentence, is that the data provide further evidence for the use of HTT2 inhibitor as a foundational therapy in patient heart failure, regardless of care setting, including patient in hospital and or ejection fraction. There are 11 papers simultaneously published in ESC. I choose some important subgroup analysis. This is the effect, efficacy of primary endpoint regarding the BMI. We see the left upper panel, you can see there is no attenuation. A patient with a very obese or very thin patient, the drug was effective, same. The effect was actually even greater in the patient with higher NT-proBNP. This in contrast with Victoria we have previously presented. And age, you can see even the patient with greater than 75 years old, still consistent effect shown here. And when you see the adverse event in elderly patient, comparing placebo and the dapagliflozin is almost the same. So published in the New England Journal of Medicine about 2 weeks ago. So, David just mentioned that in the previously in American guidelines suggest the patient with a mild reduced HTT2 was a 2 indication, 2A indication, they were added the B, but now they are revising the guideline. The guideline will change to class 1, A level A. How about the heart failure with preserved ejection fraction? Again, the indication will be class 1, level as A. And finally, we'll see some data from pool analysis of these two trial, because this is important, because this is individual patient data presented by my friend, I think, June in the same section as delivered. So the purpose of this pool analysis was mainly 4 points. The first one, we want to prove if the drug in the pool analysis can decrease the CV deaths, all-cause deaths, total hospitalization, and also to be brave to including the so-called MACE. And we will try to compare this with the previous EMPEROR trial, which also presented some pool analysis. So now put together more than 11,000 patients here. So the 99% of percentile, including patients with the ejection fraction, from 16 to 74. So this slide shows the change from the reduced to preserved. You can see the age was getting older, male decreasing in number, and the functional class become less severe. BMI was greater, and the NT-proBNP was lower. blood pressure was higher, comorbid condition was more common, and including the renal function. And this is, I think, is very important, suggesting if we pull this data together, we can see there is a decrease of CV deaths because the power wasn't enough now. It means that patient with any kind of the heart failure, you can confirm, you can suggest the drug very effective in reducing CV deaths by 14%. And interestingly, there is no attenuation of the effect in patients with a very high ejection fraction, even greater than 65%. And EMPEROR also do the so-called pool analysis, but you can see there is no difference of the CV deaths. This is first the important different point between the two pool analysis. The second is all-cause deaths, 10% reduction, again, significant. And there is no attenuation of the all-cause deaths here shown here. But for EMPEROR, because the hazard ratio of the EMPEROR and the EMPEROR PRESERVE almost equal to 1.00. So there is no data present in their paper. And the second is total heart failure hospitalization, very successful. First hospitalization, very successful. And put on the continuous curve versus the LV ejection fraction, you can see there is no attenuation of the total heart failure hospitalization, a slight attenuation of the first heart failure hospitalization regarding to LVEF. The EMPEROR also do the pool analysis to see the first admission, hospitalization, and the total hospitalization. You can see attenuation again in the patient with LVEF greater than 65. And finally, the MACE reduction by the 10%, very, very marginally effective. I have to remind you, I don't think SGLT2 will decrease MI and stroke. Probably this MACE reduction was due to the CV deaths, which was due to the heart failure reduction. Again, there is no attenuation of the MACE event. The last one is a so-called common endpoint, is CV deaths plus first heart failure hospitalization. In the pool analysis of DAPA, 22%, very significant. This is important because there is no attenuation at all. And for the EMPEROR, there's attenuation with the LVEF greater than 65. You can see quite clear here. This has been mentioned by David. This paper has been published in Nature Medicine. This slide has been shown by David. You can see only DAPA show no attenuation. Other neurohormonal inhibitor, there is a slight attenuation, especially at LVEF greater than 50%. EMPA was not effective if the LVEF greater than 60% or 65. So this is very, very important. And even the patient with so-called heart failure with normal ejection fraction, this is a new nomenclature. You can see with the LVEF greater than 60%, the drug still have effect. And when we look back to the last year, there is a meta-analysis by the EMPEROR. And now from the reduced LVEF, but now the group of the DELIVER also do the same meta-analysis. I have to remind you, this is not a patient-level meta-analysis. This is aggregate data. I'm not very convincing with the aggregate data shown here, although the p-form heterogeneity did not significantly change, suggesting the effect might be the same. But I personally do not too much emphasize about the so-called aggregate data. So, Mr. Chairman, in summary, dapagliflozin is the only foundation therapy for effective in full spectrum LVEF patient. Dapagliflozin is the only foundation therapy with proven efficacy in patients with so-called improved ejection fraction. And the DELIVER trial support the use of GT2 in in-hospital setting. The DELIVER trial and EMPEROR PRESERVE are very similar, but have some subtle difference in the design, patient characteristic, and risk level. We can say that for primary endpoint, they show similar result, but for pool analysis, they show difference in their effect on CV deaths and all-cause deaths. And finally, SGLT2 have the class 1 indication level is A in the future. I have to remind you, patient with a so-called heart failure with normal ejection fraction, probably dapagliflozin is the only one which was actually my preference. I would thank you very much for your attention.
Thank you so much, Prof. Chiang. That was a very informative talk. You went through a lot of data, and it's a real deep dive into the DELIVER study. There are a few questions coming up, but perhaps if you don't mind, I might start because I have a question that was kind of burning in my head as you were presenting all that data. And as you mentioned very clearly, and I think Prof. Sim showed this result as well, for the Paragon trial, there was a suggestion of attenuation of effect at the EF above 57%. And as you mentioned, well, the Emperor preserved showed no heterogeneity in primary endpoint of efficacy below or above 50%. There was a suggestion of attenuation of effect at higher EFs. And as you mentioned, the meta-analysis seems to suggest, the combined meta-analysis of all 5 trials seem to suggest that this may be a class effect, but you said that you were not so convinced because of the aggregate data. So if I may come to the question, what do you think is the difference in dapagliflozin and empagliflozin that would make you see this attenuation of effect for DELIVER, but not for Emperor preserved?
The true answer is nobody knows. But we can see from the, so in the DAPA HF and Emperor reduced, we see there is a difference of the mortality. You know? The total mortality in CV days was actually favoring the dapagliflozin, but not favoring on the empagliflozin. Because the empagliflozin, there is the hazard ratio was actually almost 0.9 something. And one explanation probably due to, maybe you can say the selectivity, because the EMPA was more selective. I think the actually 2 versus 1 is 2,500 something. For the DAPA is about 1,200. So most non-selective was a sotagliflozin. You can sotagliflozin is very effective. This is my guess, but nobody knows. But there's some change of the different drugs. I usually not very fond of so-called class effect. We know that if you see the data in the diabetic trial for EMPA-REG, it's very successful. But you see the vertex, almost nothing happened. So they are also very selective, the same inclusion criteria, same outcome, but there's completely different. So I think we have to examine each trial by itself instead of use class effect. But the true answer is I don't know.
No, thank you. That was certainly very informative. Perhaps I might open this up to the other panelists. Does anyone have any comments on this? Because it's a very hot topic. This question of the effect attenuation.
Can I ask? I think Prof. Chiang he did mention about the difference in diabetes. So interestingly, in the heart failure trial, we see that DAPA-HF has cardiovascular mortality in reduced ejection fraction. Emperor did not have it. But for the 2 HFpEF trial, whether it's Emperor preserve or DELIVER, both of them did not show a statistical significance in cardiovascular mortality. In diabetes, we see a totally different pattern. EMPA-REG, empagliflozin, there was cardiovascular mortality. They declared TIMI 58 with dapagliflozin, then did not show cardiovascular mortality. So, I think sometimes we have to be careful because every single trial that I mentioned here are slightly different. We cannot compare, the trial. So I think while we're trying to do meta-analysis to aggregate all the data together, yes, we're trying to find out more, but I do have some concept about meta-analysis as well. And I think none of us here can say that EMPA, REG, and DECLARE are the same. One is looking at type 2 diabetes patient at very high risk or with cardiovascular disease already. The other one DECLARE, looking at 60% of them had no cardiovascular disease. So it's 2 different group of patients. And then back again, I did mention right at the start, the Emperor preserve and the DELIVER, even though they are both so-called HFpEF trial, they are different as well. Don't forget, 1 in 5 patients in the DELIVER trial has heart failure improved ejection fraction. This group of patients was not studied in Emperor preserve. So there are, differences in trials. So I personally don't like to compare 2 different trials. It's apple versus orange. The only way to answer this question is actually put the 2 agents together in 1 trial, which unfortunately AZ and BI will never do it, you see. So I think we have to be a bit careful. It's very interesting if you look at data, Emperor preserve 41 to 49%, the effect is the best. As you go higher up to 60, 65, the effect seems to wear off. But again, the subgroup analysis, the p-value for heterogeneity is not significant. DELIVER was a totally opposite mirror image. The effect was stronger above 60%. As you go towards 41 to 49, the effect actually wear off, in a sense. So it's a total mirror image of Emperor preserve. So can we then say that don't use in 41 to 49? Cannot, right? the subgroup analysis, again, subgroup analysis take with a pinch of salt. Its p-value for heterogeneity is still so-called not significant. So I won't say it's a class effect. I totally agree. It's a bit like how we use beta blocker in heart failure. Can we say it's a class effect? No. We can't use atenolol, we can't use propranolol. But SGLT2 inhibitor, same thing. I would say that can't say it's a class effect. I can't use canagliflozin. I can't use other SGLT2 because they've never been studied. So what I can say is maybe this term that's more appropriate, heart failure specific SGLT2 inhibitor, a bit like beta blocker, heart failure specific beta blocker. And for now, the AHA, ACC, and the ESC, they do recognize two of them, EMPA and DAPA, all right? So I personally think that it's a better term we use, heart failure specific SGLT2 inhibitor. As for which agent is superior, I'm really neutral here because of you can't really compare two trials. It's like, the DAPA and the liver, I know when pulled together, there was a 14% reduction in the cardiovascular mortality. But strictly speaking, if I give this to a patient whose ejection fraction 60 to 65, I will still tell them mainly to reduce your heart failure hospitalization because in the liver trial, you just missed that little bit.
Yeah, I agree with you. Actually, the first conclusion was, I think two trials was quite the same, but there was some subtle change difference. So I also agree with you, I don't believe the meta-analysis. And also poor analysis, scientifically lower level. So I agree with you that at least we can say, according to the delivery inclusion criteria, we can observe some important things. No attenuation, good for the patient in hospital, and good for the patient with the so-called heart failure will improve ejection fraction. That's the 3 points. Thank you.
Thank you very much. A very nuanced and balanced interpretation of the data. So perhaps I might go back to some of the questions, if that is okay, that I just noticed on the chat. So there's a question about which I might direct to Prof. Sim with regards to the sex specificity. I assume this is based on the Paragon trial data that Prof. Sim showed just now. So there was some, of course, significant heterogeneity in the multivariate analysis in the Paragon trial by sex. And I guess this is the multi-million-dollar question. Females seem to derive more benefit versus the males. I think the question here is why. Prof. Sim, do you want to take the question?
Yeah, so I think there was a publication by the Paragon group. I did take part in the Paragon HF as well. Again, I had to remind everybody, Paragon was a neutral trial. So looking at subgroup analysis on neutral trial, sometimes it's not that, you have to take a pinch of salt, right? You only start looking at subgroup when the trial is positive. But I think there's some postulation. Nobody knows exact mechanism. It's a bit like, CRT responder. We know that female patients respond generally better than male patients. Exact reason, we're not sure. It could be due to specific sex differences, hormonal differences. But the other postulation is those patients, because you see, when we recruit patients into a heart failure trial, you will not have different you will not have different ejection fraction recruitment. The ejection fraction so-called criteria still apply the same for both gender. But there are some postulation that female being smaller in size, heart size being smaller, their ejection fraction, what is normal range, may not be the same as a male patient. Female so-called normal ejection fraction or preserved ejection fraction may actually be slightly higher than a man. So because of that, we think that some of these female patients are recruited, even though, we call them preserved ejection fraction, but actually maybe a bit on the lower side, maybe actually mildly reduced for them already. That is some postulation why it works for this group of patients. And back to Jack's question previously, do we need to have, a sandwich group of mildly reduced? I think we do need, because a lot of data now show that 41 to 49 actually do not behave like a HFpEF patient. They actually behave more like a 40%. So somebody stuck right in 45 actually behave more like a 40% rather than 50%. So I think the reason for changing the terminology, previously what I call mid-range to mildly reduced, is to emphasize this group actually behave more like a reduced, so that we will treat them more like a reduced, giving your, ARNI, your beta blocker, and even MRA.
Okay, thank you very much. The next question, I think I might just open up to the panel. It's a question on diagnosis. And the question really is how often we need sort of invasive hemodynamic studies, right heart caths to diagnose HFpEF, and whether there's any role of LV strain to diagnose elevated LV filling pressure. Does anyone want to take this question?
I will defer that to Prof. Chiang maybe to take this one.
Well, if you want to write a paper to submit, a chance to have submission, and the hemodynamic measurement by invasive is required. Because when you review an article, if there's something that you might need to have that. But for clinical practice, we rarely do the hemodynamic unless there is equivocal cases. So I personally very rarely refer the patient to do the so-called hemodynamic study to confirm the patient if the patient has so-called HFpEF. Usually my way is according to the inclusion criteria of the trial, exclusion, the therapy, the titration, and we'll expect the result. So that's the beauty of the clinical trial. What this is so important for clinician. Actually, we don't need to know the mechanism. We just do that, you can expect. So that's my policy, and actually very good, a good strategy for GP. But for the reason of the mechanism of the hemodynamic is you can leave it to the scientist or some researcher. That's my answer. Thank you.
Thank you very much, Prof. Chiang.
I think in real life, we don't do a lot of hemodynamic study for this group patient. Most of them will be quite clear-cut just based on the imaging, the echo finding, and the biomarker. I think even the guideline, they do not encourage, we don't start going after this talk, doing right heart study everybody. But there will be a subgroup of patients where, the biomarker is elevated, but just slightly elevated, not high enough to account for it. And yet the patient has typical sign and symptom of heart failure. I think in that group that you can't pinpoint, you're still not sure what's the diagnosis, then there might be a role for right heart. But again, it is not common. We don't have to do it for most patients. I would say majority of patients do not have to go to the hemodynamics. It's really in cases of what we call diagnostic uncertainty. Yeah.
I absolutely agree with that. Thank you. And I think maybe from the perspective of the LA strain, I will just say that from in our center anyway, we don't really use LA strain to diagnose HFpEF or elevated LA pressure. And of course, I think one of the main limitations with LA strain is that it's age dependent and we don't really have optimal age adjusted cutoffs for LA reservoir and pump strain. So I think that's the main thing to say. The next question is with regards to the trial, to the patient inclusion criteria, which I might direct to Prof. Chiang. The question was with regards to patients with amyloidosis. So patients with amyloidosis included in these studies?
No, we actually didn't check if the possibility because we didn't do the biopsy and didn't do that special imaging study. In a large trial such as the INDELIVER, more than 5,000, it's impossible. So it's possible the patient with a good LVEF greater than 60, there might be some patient with amyloidosis over there, but hypertrophy was excluded because we have the echo data. But we didn't pay too much attention to exclude amyloidosis. We don't know that. Thank you.
Okay, perfect.
Sorry, Julian, maybe I think the same in Emperor Preserve. We did not exclude amyloidosis as well. But I'm quite sure both trials are so big. Both I have about 6,000 patients. I'm quite sure there will be some amyloidosis that sneak in, you see. So from if you look at the literature, they say that in the earlier study of HFpEF, why it failed is because of they say that more than 10% of these patients who got recruited in the trial may actually have amyloidosis. But fortunately, I think in recent year with the advancement in echo imaging, if there is very florid, suggestion of amyloidosis or echo, it will have picked up. So hopefully we kept the number of amyloidosis in both trials to a minimum.
Thanks. I think we have to move on so that we can use the case to rediscuss all these things. There are a lot of good questions here. So upper age limit of benefit, I think in the trials, they didn't show any age limit that I think potentially any age with heart failure probably will benefit. And whether you need to look at change in LVEF in patients who have HFpEF with treatment. I think what I like about all this heart failure trial, they don't track BNP or or re-echo them. They just look at clinical outcomes, which is what we should be focusing on. So again, maybe we move on. So Dr. Hawani is going to talk about a case example. Is going to flesh out the issues of problem of diagnosis, which is what a lot of questions are about. Then Julian is going to talk about a case with a problem of management. Then we can discuss around those two big topics. Dr. Hawani, please.
Yes. Okay. Thank you so much, Dr. Jack. So actually, this is one case that we have been discussed before. So this is a male, 65 years old, a lecturer. He was referred by an interventional cardiologist, one of my colleagues. This patient presenting with a shortness of breath, especially when giving a lecture, and also easily fatigued. The PND is actually not clear. The patient can still lying flat. Mouth, leg swelling, but again, it's on and off. No chest pain, no palpitations. The risk factors, the patient was hypertension, dyslipidemia, and also ex-smoker. The patients underwent PCI 2 years ago, and then also have an atrial fibrillation since 3 years ago, COPD, quite well controlled, CKD stage 3 with a history of hyper-K, osteoarthritis, and also recurrent gouty arthritis that limit his movement. So there's many comorbidities in these patients. And his current medications was on edoxaban and then nebivolol, already 10 milligrams, and then amiodarone for the atrial fibrillations, and then atorvastatin, long-acting nifedipine, telmisartan, and also allopurinol. And then
take a quick pause here. This is a great case, by the way, Dr. Hawani. This seems like a case that we're seeing day in, day out. Maybe I can pick on Alan first. So you got this guy, you did PCI 2 years ago, come back with very non-specific symptoms. You mentioned BMP, everyone. Is that what you do, or you're going to recap this patient?
Yeah, in our setting, BMP would start first.
Okay.
So you will suspect heart failure straight up for this patient? Or
No, the clinical history that he is also on COPD, and I will assume that his chest film has also excluded any other significant lung pathology. If that is being done, then we would definitely move along the heart failure diagnostic pathway.
Thanks, Alan.
So, these patients, so actually the COPDs was quite well controlled. And from the pulmonologist say that the COPD is well controlled. The patients never have a wheezing and something like that. So it's the COPD, they may say that it's well controlled with all the medications, something like that. Yeah, but the patients still feel shortness of breath and also easily fatigued. Okay, can I move?
Yeah, please. Go ahead.
Okay, then from the physical examinations, these patients have a BMI 30 kg per meter square, so considered as an obesity patients. With the blood pressure, it's a bit on the high side. The heart rate is already on 50 to 55 regular because the patients have atrial fibrillations but paroxysmal, and then normal GVP, and then we can hear the S4, the lung clears, and no bipedal edema. The ECG we can see in here, normal sinus rhythm with the possibility of old myocardial infarctions in the inferior lead. So as I already mentioned, that these patients was referred from my colleague for interventional cardiologist. So he did the angiography evaluations because considering that these patients underwent PCI 2 years ago and still feel shortness of breath, although there's no chest pain. The angiographies showed no difference than the previous angiography. So the chest X-ray show a mildly cardiomegaly with the no pulmonary congestions. And the creatinine level is 2.27. The eGFR is still 31. The creatinine clearance is about 34. And surprisingly, the NT-proBNP is 253. So if we see based on the cutoff from the NT-proBNP, it is abnormal. But these patients have multiple comorbidities. So I'm asking myself at this moment.
I also like to take a quick pause here. So this, again, great case. It's so typical of the cases. I'd like to ask David first. You have a depressed EGFR and renal impairment. How much correction or weightage do you put on the BNP here for diagnosis of heart failure?
Actually, with a depressed EGFR in a renal impairment, you will expect the NT-proBNP to be higher. But in this case, we have the reverse. The NT-proBNP is raised, but it's just marginally. This patient would have been recruited in Emperor Preserve or Deliver trial because of NT-proBNP less than 300. But don't forget, Hawani presented this patient a BMI of 30. we do know that obesity is associated with a lower NT-proBNP, right? So that could be the reason why the NT-proBNP is underestimated. So always do take note that obesity will underestimate the NT-proBNP. And to make matter worse, this group of patients HFpEF tend to be in a big site. So this may be one of those cases that you may want to consider a right heart study or a stress echo to look for a rise in the wedge pressure or the E over E prime.
Correct.
So I'm sure Hawani is going to show us the echo next.
Yeah, so then I did an echo, and the echo showed the LVDD was 52, the LVMI was quite big, 179. The LAFI is slightly abnormal because we say the LAFI is usually the cutoff we use in echo is 34. Somehow the echo findings, especially in the plaques window, is not that good, so suboptimal echo window. Concentric LVH with the preserved LV systolic functions, the ejection fraction around 57%. Diastolic dysfunctions with a low probability of pulmonary hypertension and normal RV contractility. So I did the echo.
Maybe I did take a pause here again.
Sure.
So again, I must acknowledge I'm echo clueless and also Dex clueless. So I asked Prof. Chiang here. I mean, this is quite a very good case. BNP a bit borderline. What parameters on echo are you actually hunting for to add on to the diagnosis, Prof. Chiang?
Yeah, I usually see two things, probably simple one, LV volume index greater than 35, and also E over E prime greater than 15. That is my personal, usually taking in the clinical trial. Because I'm not an echo man, you know, so I usually see that combined with symptom and NT-proBNP, I will make a preliminary diagnosis. Thank you.
How often do you look at the PA pressure in this case, and how?
Well, PA pressure is depends. It's not very, I think, very depends on the measurement. Sometimes they vary by 5 or 10. So I'm not very fond of the. Although PA pressure is maybe one important criteria. By my personally, I didn't quite. If the PA pressure is high, for example, 40 or 50, that's probably have some impact. But if the 35 or borderline, I probably will skip that. Thank you.
Julian, any comments so far, or would you still say you need a right heart cath after looking at this?
Yeah, so I think I do agree with Hawani. This is a bit of a scratching my head a bit. I look, I mean, the patient does have concentric LVH, so I think that's one point over there. The septal and lateral E primes are both depressed, but the E over E prime at average 8.98 is normal. I understand he has AF, right? So this is probably PAF because he's in sinus for this echo. Sometimes you get caught out because in sinus, in AF, a septal E over E prime above 11 would be considered elevated pressure. But in this case, it's normal as well. I know from a trial perspective, we tend to take diastolic dysfunction with structural heart disease, and that's either LVH or dilated LA to diagnose HFpEF. But in this case, together with the clinical symptoms, of course, but I personally put a lot of weight behind a dilated LA because a normal size LA tells you that this LA has never experienced high pressure before. Two caveats to that. One is measurement error. Two is in the acute phase of the first presentation of HFpEF, the LA size may be normal. But this normal LA size and this normal E over E prime kind of turns me off HFpEF a bit, with the caveat that we know that sometimes the elevated pressures only manifest with exertion and with stress and not at rest. So based on these echo parameters, I would say, unless the clinical picture was very suggestive, I would not be thinking of HFpEF in an echo that looked like this if I was just the imager looking at the echo pictures.
Yeah, correct. So I also a bit confused about these patients because there's many comorbidities. So again, my questions is actually, is he a HFpEF patient, considering that it's very challenging to diagnose HFpEF in these patients because these patients have a clinically unclear due to patients with the conditionings, limited physical activity because of the osteoarthritis and recurrent Goudy arthritis. Patients also have a paroxysmal AF. We know that there's an overlap symptoms between heart failure and also atrial fibrillations, and multiple comorbidities that can also cause these patient symptoms, shortness of breath and easily fatigued. So this is the common pitfalls that lead us to underdiagnose of HFpEF at this moment. So once I have this patient, so I also challenge myself. So whether this patient is truly HFpEF or not. So this is what happened in my brain when I'm trying to diagnose these patients, because we know there's many factors in these patients that can increase the probability of these patients to get HFpEF, DOE, easily fatigue, which is the symptoms of heart failure. The risk factors, hypertension, atrial fibrillations, overweight, that have a high risk to get HFpEF. The E prime septal, as what Julian mentions, it's 6, so it's low. Either the E per A is also less than 1. The LVMI show high, and then the LAFI is also slightly abnormal. But in the other side, these patients also have a few factors that may decrease the probability of HFpEF, because he has a deconditioning and then CKD stage 3 and COPD that might also cause the shortness of breath and also the easily fatigue. Somehow with all these CKD and also patients with the suspected as HFpEF, the NT-proBNP and also AF, the NT-proBNP is subtle increase, so it's not that high as what Prof. Sim mentions, with a normal PASP and low tricuspid regurgitation screen-max. So I decided to look based on the scoring system. I use the ESC. I also agree with Prof. Sim. I rather use the ESC instead of the ACC HFpEF score. But somehow, because these patients have this functional major, the morphological was also major, because considering the LVMI and regional wall thickness was quite thick. So, but the biomarker, we cannot say that it's abnormal, because considering that the patients on atrial fibrillations. So the results of this score is 4 actually. And then in terms of the HFpEF score, these patients have a hypertensive atrial fibrillations and also elderly. So again, the score is also 5, which is considered as intermediate probability. So that's why I scratch my head again for these patients, but he still feel easily fatigued, especially that one, he really concerned about that. And then also shortness of breath. So based on what already mentioned by Prof. Sim in intermediate probability score, what should we do? We should do a stress test. But again, these patients unable to do exercise and with a poor echo during stress test, I'm pretty sure we tried before. So we use the hand ergo cycle instead of the leg ergo cycle. So we use the hand ergo cycle, but somehow we cannot see the echo view, because it's very, very poor considering the patients with COPD. So at that moment, we do the right heart catheterizations.
Wow, so I was about to stop you there before you showed this.
Okay, sure.
I thought, everyone said this is not usually you do a right heart cath.
Because you asked me to deliver questions.
Put my panelists on the spot now and say yes or no, HFpEF, yes or no. Alan, HFpEF, yes or no?
I think due to the diagnostic uncertainty, without the right heart cath, and I'll go with the symptoms the old-fashioned way and say it's a yes.
Yes. Julian, yes or no?
I don't know. Personally, with the history of COPD, although well controlled, with the obesity, I may have stopped here based on the echo.
So I personally would say probably no, and I'll look harder for daytime somnolence as well, and not to miss a severe OSA in this patient with all these myriad symptoms.
Yep.
Before we put the rest of the professor on the spot, looks like you went to a right heart cath, which is probably the correct.
Because yes, that's right. So because I already tried to consult our colleague from the pulmonologist, asking whether there's any problem with the pulmonologist. They say no, and then I'm trying to give the furosemide as well. I'm trying to do the decongestations as well. Yes, sometimes it's better, but it's not that significantly better in terms of the symptoms. So again, I ask the patients whether you want to, so I discuss with the patients whether you want to do the right heart catheterizations with all the risk and benefit and everything. And the patients was agree at that moment to do right heart catheterization. So I did the right heart catheterizations at that moment. And surprisingly, the wedge pressure is not high. It's 11 until 14. To be honest, it's 15, the cutoff. So I try. Okay, come on. We go through whether there's any, any technical issue or whatever, whether the wedge pressure become 15, but somehow cannot.
Okay, so maybe I take a pause here because this is not commonly done. So maybe I can get David to give some quick pointers. When you do a right heart cath, what is the parameter we're looking at to diagnose HFpEF?
Yep. So first I must say I'm very proud, Hawani. I think I taught you well. So I absolutely agree. I would have done a right heart cath in this patient. Remember, previously I say in those intermediate case, especially this is somebody COPD, I cannot be very sure this HFpEF or not. I think this is a very clear-cut case. A right heart is so useful. And there's two ways of doing it. First, a normal wedge should be less than 15, all right? So you'll see you're getting 11 or 14, you know, when you get 14, you bang your head, say, wow, why can't it just be 1 or 2 points higher? So there's two ways of doing it. You can either do a bicycle on the spot for the patient to cycle, but sometimes it's tough for the patient. What you can do is challenge them with fluid challenge. That will also bring up the wedge pressure. So a wedge of 18 to 20 is definitely significant. It is definitely elevated. But just be careful. Sometimes I've seen it in the past, you know, during my training overseas, where we give fluid challenge, we may tip over the patient into APO. so you may need to, after the fluid challenge, give them some diuretic, all right? So again, normal wedge is 15 and below, but once you give fluid challenge or exercise the patient, you see a increase in the pulmonary pressure and an increase in wedge pressure, then you can more confidently say that this patient has HFpEF. In fact, being able to record a raised wedge pressure is more so-called, is the best evidence of HFpEF compared with echo finding biomarker and the rest of the stuff.
So after a long discussion with the patients, with all the recent benefit, then the patients was able to do right heart catheterization. So we did the right heart catheterization, show that the wedge pressure was increased, and then that's correct, Prof. Sim, the patient's getting breathless, as we can see in here, based on the respiratory, we can see in here that the patient's getting breathless, and then also a tachycardia. So at the moment, after we gave the NaCl, then we gave the furosemide directly at that moment. So surprisingly, the PVR is not increased. The PA pressure is a bit increased, probably because of the COPD as well, after we do the fluid challenge test. So again, we diagnose these patients as a confirmed HFpEF with a paroxysmal AF and CKD stage 3 with all the comorbidities. And then I noted that it is not included in this kind of patients not included in the liver or emperor preserve, but after long discussions again with the patients, then I add on SGLT2 inhibitor for these patients. And I continue all the medications. And then 1 week after, the heart failure nurse called the patients. The patients feels well, actually, especially in terms of the shortness of breath. He feel better, though it's not that quite significant, but the easily fatigue, he still feel very easy to feel fatigue and everything. So when I asked the patients, he said that his heart rate can be as low as 47 until 50. So at that moment, I also think that probably because of the heart rate is too low. So I reduced the nebivolol dose to 7.5 and consult the cardiac rehabilitations for exercise prescriptions. And I also actually suggesting to these patients to do the atrial fibrillations, ablations of the atrial fibrillations. So during follow-up, the patients was doing great. Actually, the creatinine even better in 6 months. And the potassium is even surprisingly be normal, 4.6 after we give all the medications. So I think the key conclusion from this case, the results were consistent with the undiagnosed HFpEF as demonstrated by increase of the pulmonary arterial pressure and also wedge pressure with fluid challenge test. Then probably in certain hospital, we also don't have the ergo cycle to do the stress test. So fluid challenge test may be an alternative in patients who are unable to do exercise. And HFpEF would remain undiagnosed, especially in deconditioning and multiple comorbidities patients without comprehensive investigations. And sometimes in some case, we need invasive hemodynamic at rest and also at stress. Thank you.
Thanks, Hawani. That was a fantastic and great case. Really, congratulations. So we'll go on to Julian. Sorry, I gave you less time, Julian, but now it's a treatment problem. So I presume it's even worse discussion. But Julian, please.
Okay, thank you. Can you all see the slides?
Yeah, go ahead.
Oh dear, how do I make this? Okay, so my case, I think, is not so much a treatment problem, but I mean, SGLT2 is generally a very well-tolerated drugs. So I thought what I do is I demonstrate a case where I thought might be a bit more inclusive and was deliver-like. So just to go through and generate some discussion on the case. So not as complicated as Hawani's. This is a 71-year-old Chinese lady who presented to us, I think, 6 years back. She was quite well, independent, 71-year-old, good 71, but had significant cardiovascular risk factors, hypertension for 7 years, dyslipidemia. The non-HDL was not too bad, reasonable, 2.5, and with diabetes for 5 years, that was relatively well controlled as well. 3 medications, metformin, atorvastatin, and enalapril. But she came to us in June 16 with chest pain. She was slightly hypertensive, which we attributed to the pain. The clinical exam was normal. Biomarkers were mildly elevated. NT-proBNP was normal. There was no shortness of breath. The ECG was unremarkable. It was in sinus rhythm. But this was the coronary angiogram. The shots on the right was shows the proximal LED, on the top right, sorry, shows the proximal LED with a very tight proximal LED lesion. And halfway through, she started getting chest pain, and then the LED started looking like this. So PCI was performed straight away with good angiographic results after placement of drug-eluting stent. And the echo at the time showed an EF of 46% with some regional wall motion abnormality and morphologically normal valves. So she was discharged well on day 4 of the non-STEMI on aspirin and ticagrelor, DAPT, as well as gastric protection. Bisoprolol was started as well for the ACS, and the atorvastatin was increased to a high-intensity statin, and a GTN spray was added as well, PRN. We continued her on metformin and enalapril at the time. This lady was reviewed in clinic 4 months later, was completely asymptomatic. I had completed the rehab. Clinical exam was normal. Non-HDL had improved with the statin intensification. A1C was good. The repeat echo prior to seeing us showed that the EF had normalized, and the patient was then discharged to primary care in 2016. So she was referred back to us recently in March 2022, and this time she had developed shortness of breath, orthopnea, and some bilateral lower limb swelling. Her medications at this time had been optimized to 4 medications. She was on aspirin, enalapril, metformin, and atorvastatin. So taken care of quite well in the primary care setting and was quite okay until recently. Heart rate was normal. Blood pressure still remained slightly elevated at 150/54. Clinically, when we saw her in clinic, the JVP was elevated in a seated position. She had bilateral inspiratory crackles and bilateral lower limb pitting edema to mid-shins. And she was admitted from clinic for IV diuresis. These were her admission labs. Her NT-proBNP was raised at 1,003. Her BMI was normal. A1C and non-HDL targets were reasonable for age, and she diuresed about 1,006 mils over 2 days. A repeat echo was requested, and this is what it showed. You see that the ejection fraction is normal, and the LV wall, however, is quite markedly thickened, and it looks like concentric hypertrophy. The LA is also dilated in this case. This was the diastolic parameters. The LA was dilated. The septal and lateral E primes were decreased at 6 and 4, and the EA ratio was high as well. So the echo showed preserved EF, concentric LVH, moderately impaired LV diastolic function, and moderately dilated LA. So together with her symptom signs, elevated NT-proBNP, and these structural abnormalities, she was diagnosed and managed as HFpEF. Because of the concentric LVH, we went on to check the blood pressure, and she was deemed to have this isolated systolic hypertension with a systolic BP of 140/160. Her ECG, because of the LVH, as well as what we thought was slightly thickened RV walls as well, did not show small complexes to suggest amyloid. So we added on dapagliflozin for this lady who had an improved EF in an inpatient setting for HFpEF. And because of the Paragon data, we also changed her enalapril to Entresto, which we hoped would have a good effect on her blood pressure too. We discharged her with an outpatient targeted echo for GLS, just to look for apical strain, to look for strain. And we also requested for an outpatient 24-hour blood pressure monitor to assess for hypertensive heart disease. And I guess the main discussion points we had, I was thinking of in this case with regards to the inclusivity that Professor Chiang was mentioning in the DELIVER trial. is how we can consider dapagliflozin for patients where there is improved ejection fraction. And perhaps something that we can discuss is this concept of this the deprioritization of the ejection fraction. Do we think that perhaps there could be a role for earlier initiation of SGLT2, given that there were symptoms and signs of heart failure with a raised NT-proBNP prior to the transthoracic echocardiogram? So that's my presentation. Thank you.
Thanks, Julian. Also a very common garden variety case and good presentation. Prof. Chiang, maybe you'll take your opinion because we're running out of time. So we're just going to go around to call for teaching.
I just wonder, after the first admission, do you consider to add HGT2 at that time? Because we know that you can prevent heart failure admission, especially demonstrated in DECLARE trial and also in the EMPERAC. Actually, in the first time admission after PC, I think the LV function is normal. Am I right at that time?
Yes, that's right, Prof. Chiang.
Yeah. So I think there is for me, I will actually at that time I will actually maybe stop the metformin and put HGT2 to prevent heart failure. That is my point. Or add on, because A1C is only 6.4%. So I probably might discontinue metformin and put HGT2 at the first beginning.
That's a great comment, Prof. So I think, yes, that is something that we certainly considered. I think 2016 at the time, EMPERAC had reported already, and that drug was available. The managing team at the time had decided that the glycemic control, they took a more glucocentric approach, I think, at the time. And so the SGLT2 was not given. But your point is well taken. I think that certainly could have been considered at an early stage, yes.
Thank you.
Yeah.
David, your teaching comments for this case?
I would agree that, heart failure is best treated at, earlier stage A or stage B. This patient definitely have diabetes. I would switch much earlier. If the HbA1c is not too high, actually, I will just take up metformin and use SGLT2 inhibitor. I suppose way back in 2016, maybe the drug was still quite expensive. There was still no reimbursement yet. That may be one reason why the patient wouldn't switch over. But as for Julian's question, I'm very comfortable with a clear-cut heart failure case nowadays before getting an echo to start an SGLT2 inhibitor, because we know now that the drug, whether it's DAPA or EMPA, it works across a whole range of the ejection fraction. Only after getting echo, I get an unexpected result like hypertrophic cardiomyopathy or amyloidosis, then I will back off the drug. If not, I think it's pretty safe to use the drug before the ejection fraction is known, right? Why wait, because that period of 2 to 3 weeks waiting for echo, patient may suffer another worsening heart failure or worse still suffer with cardiovascular mortality.
Alan, your any points from you for this case?
Yeah, I think from a developing country perspective, the main advantage for many of these drugs are to reduce hospitalization, because these are the ones that you have to get to hospital and try and prevent all this. The results from both EMPERAC and DELIVER has demonstrated an early separation of the curves. And I believe this is also demonstrated for hospitalization data. So I think the sooner we can identify those at the highest risk and then invest in these patients with SGLT2 inhibition, perhaps can provide us additional advantage in terms of preventing hospitalizations, at least the unnecessary ones. So I think this CME is really important. And I think, as you know, I'm also not a heart failure person, but I've gained a lot from listening to all the experts, including Prof. Chiang, who's one of the key investigators for these landmark studies. Thank you.
Dr. Hawani, I mean, this kind of case, diabetic, and already MI, CV events, and now heart failure. Is there anyone you will not start SGLT2 inhibitors for at this day and age? Who are the group of patients?
Wow. It's a very tough question. I think you need to deliver to Prof. Chiang about these kind of questions, but I'll try to answer that question. So basically, once the patient was diagnosed as heart failure, we know that now whether a patient is reduced ejection fraction, mildly reduced ejection fractions, preserved ejection fractions, we can give SGLT2 inhibitor like what Prof. Sim already mentioned. So once you diagnose these patients as heart failure, as long as there's no contraindications, then you can give these patients SGLT2 inhibitor. And then for the type 2 diabetes, probably only diabetes without any other risk factors, so early diagnosed diabetes, that kind of patients probably you cannot add on SGLT2 inhibitor. But I think hardly we can find patients with diabetes without any cardiovascular complications or without any cardiovascular risk. So yeah, I think that is my answer.
Thanks, Hawani. So we have run out of time. So maybe I can have a final concluding remark for my two professors, starting with Prof. Chiang, then Prof. Sim. Prof. Chiang, please.
Yeah, I think these 4 trials has demonstrated the usefulness of this kind of drug in heart failure, no matter what is the LVEF. You don't need to wait until the echo. I think it's a very landmark trial, and we should use even earlier. For the case, we may, after the diagnosis of diabetes or CKD, you can prescribe before the event. Thank you.
Yeah, so I think Emperor Preserve first established the role of this drug in mildly reduce and preserve ejection fraction. And then with the deliver, it added more weight, to the evidence. Plus, we now have evidence in heart failure with improved ejection fraction as well. And both the deliver trial and the MPulse trial and other small trial both show that it's very safe to use acute heart failure as well. So by day 2 or day 3 of heart failure, when they're stabilized, we can use it as well. The only caveat I would say I can think of is the patient that I will not dare to start SGLT2 inhibitor is those patients who are very sick and not eating well, they're in a fasting state. You may want to wait till they're out of the fasting state because you don't want to cause a ketone acidosis in this group of patient.
Thanks to the two professors, and I'd like to thank my co-chair, Julian, for the great moderation, my panelists, Alan, for those great comments, and Hawani. I really love your presentation. That was a very, very nicely presented diagnostic case.
Thank you so much.
And we hope not to see that case in our clinic, especially for me. Thank you very much. So thanks to all my faculty and thanks to all the great questions. Sorry we couldn't take every one of the questions. And thanks to all the participants for staying the 90 minutes. Thank you and goodbye.
Thank you. Bye-bye.
Bye-bye.
Bye.